care, including cancer services across the cancer continuum. At CancerCare Manitoba, we respect the spirit and intent of the treaties and treaty making and remain committed to working in partnership with First Nations, Métis, and Inuit peoples in the spirit of trust, reconciliation, and collaboration, while also improving cancer control and outcomes for all Manitobans. For my own part, being an immigrant to Canada and to Manitoba, I have committed myself to learning more about our First Peoples in the country and in the province. But also in my role as a primary care provider and also at CancerCare Manitoba, I have committed to doing what I can do. And I will say initially it sounds daunting and you feel like you're only one voice. But over time, I have learned that every voice that speaks out matters. And my commitment is to continue to speak out every time I see inequity and inequality that's impeding the care of patients in Manitoba. So before we begin our presentations, I'd like to go through some 3 admin items. Firstly, please note that this webinar is being recorded so that we can make it available for viewing after today. Within the next few weeks, it will be added to the CancerCare Manitoba website. Also, the last 25 minutes of the webinar will be devoted to questions from you. We have already received a number of questions prior to the webinar, and we'll cover those first. If you have questions as we go along, please add them to the Q&A box, which can be found at the bottom of your screen. And now on to the presentation, which has 3 learning objectives. By the end of this session, we hope that participants will be able to explain the changes to colorectal cancer screening in Manitoba, explain the benefits of using FIT to screen for colorectal cancer, identify suitable indications for testing with FIT, and appropriately use FIT for colorectal cancer screening and surveillance. So we have 3 speakers today to help us go through these objectives. Dr. Stimpson, who's the ColonCheck Medical Lead at CancerCare Manitoba, the Provincial Lead for Gastrointestinal Endoscopy, and Chair of Gastrointestinal Endoscopy Standards Committee. 2, Dr. Ali Khan, who's a general surgeon and the surgery site lead at the Grace General Hospital, with an interest in minimally invasive surgery, endoscopy, and acute care surgery. And Laura Coulter, who's the screening program manager at CancerCare Manitoba Screening Programs. Laura will be our first speaker, and she will provide a recap of changes to colorectal cancer screening covered more thoroughly in the webinar from June 2023.
Great, thank you, Dr. Fatoy. So as most of you may be aware, on June 20th of this year, Shared Health Manitoba announced a clinical practice change affecting colorectal cancer screening in the province. Fundamentally, there were 4 prongs to this new model of care. Firstly, could you change the slide, please? Thank you. Firstly, the provincial colorectal cancer screening test changed to the fecal immunochemical test, more commonly known as FIT, from the fecal occult blood test, or FOBT. Secondly, FIT distribution was centralized under CancerCare Manitoba ColonCheck program. ColonCheck will automatically mail a FIT to all Manitobans upon turning 50 years of age. And kit mailouts can also be initiated by a healthcare provider using the FIT requisition form available on most EMRs or on the CancerCare webpage, or by a patient's online request to ColonCheck. Patients are also welcome to attend in person or call the program directly. Completed test kits are returned to CADM Provincial Laboratory for analysis, simplifying the testing process and reporting of results. And the 4th and final prong was the management of test results. ColonCheck is responsible for communicating all patient FIT results and initiating all abnormal follow-up referrals to colonoscopy. CADM Lab will provide a fit result report to healthcare providers in patients who have identified a tied provider. The expected benefits of this new model of care are many, including an anticipated improvement in early cancer stage detection rates and an overall reduction in mortality. This is due to the high-quality fit sensitivity in detecting early symptoms of colorectal cancer and advanced adenomas. We expect an increase in screening participation as the FIT is a very easy test to do. It requires only one sample and has no dietary or medication restrictions. Essential to the success of any cancer screening program is routine participation within the eligible population. And so ColonCheck will distribute FIT kits according to colorectal cancer screening guidelines and follow established patient pathways. And this includes patient engagement, recruitment, education and recall, to result management and abnormal follow-up. We also have fail-safe practices, which will help to ensure that no patient falls through the cracks. And as ColonCheck maintains the colorectal cancer screening database registry that contains all colorectal cancer screening histories for Manitobans 35 years of age and older, we're able to evaluate and report on the performance of colorectal cancer screening in the province and monitor for a high standard of testing quality. Now, with all of that being said, I just want to take a minute to dig a little deeper on how FIT results are being reported. As mentioned, ColonCheck will mail FIT kits to eligible Manitobans either upon request or automatically through population-based recruitments. Now, this not only ensures that eligible people are sent a FIT test, but it also provides for equitable access to this high-quality test across the province. Completed FIT kits are returned to CADM Lab for analysis. Test kits can either be returned by dropping off the completed kit at a shared health lab where it's going to be redirected to CADM Lab or at a Canada Post outlet. CADM will send a qualitative electronic result of either normal, abnormal, or indeterminate to the patient's healthcare provider if one was indicated on the FIT return form. Also included in this test result is guidance on the patient's risk for colorectal cancer that's been calculated from the patient's self-reported data on the FIT return form. In the near future, we hope that this test result will also be available on eChart. If the result was indeterminate, you can be assured that ColonCheck will be sending a repeat test to your patient to complete. CADM will send a quantitative electronic result to ColonCheck for result management. The quantitative cutoff is 100 ng per ml. If the FIT result is less than 100 ng per ml, ColonCheck will send your patient a normal result and automatically recall them in 2 years if they continue to be eligible at that time. If the FIT is abnormal, ColonCheck will promptly initiate the referral for follow-up colonoscopy. If after investigation, the patient is determined eligible to return to FIT testing, ColonCheck will automatically send them a FIT when they're due to return to screening. If after investigation, the patient is determined ineligible to return to FIT testing, ColonCheck will send the patient and their healthcare provider a fail-safe reminder letter when it's time to return to follow-up colonoscopy. A FIT test will not be sent to these patients in the future. So going back to something that I mentioned before, which is I want to stress that ColonCheck is going to automatically initiate follow-up investigation for patients having an abnormal FIT test. Upon receiving the abnormal test, ColonCheck will phone the patient, advising them of their result and schedule a pre-procedure health assessment with the program's nurse practitioner. A result letter will be sent to the patient following the phone call. At the pre-procedure assessment, the NP will determine the patient's readiness for direct-to-scope referral. If a direct-to-scope referral is determined inappropriate, ColonCheck will contact the patient's healthcare provider for guidance or arrange for a consultation with an endoscopist. In the majority of cases where referral is appropriate, the NP will review bowel preparation for the procedure, arrange for blood work if needed, advise on what's to expect at the colonoscopy, and answer any questions that the patient may have. Following this appointment, the referral will be made to the appropriate SDO following the provincial endoscopy referral processes. Now, important to note is that ColonCheck will engage with the healthcare providers every step of the way, including them in letting them know that a referral has been made for their patient, indicate where the colonoscopy is taking place, and ensure that they are copied on all procedural and pathology reports. Final outcomes, such as eligible to return to FIT testing, will be provided in letter form to the patient and their healthcare provider once follow-up has been completed. Last thing I just want to touch base on is if healthcare providers require any other means of support or information or education, we have a variety of resources found on our website to help support you in your practice. And you'll see the web page is just indicated below. So to view any of our healthcare providers, visit cancercare.mb.ca/screening/healthcare providers. So, thank you.
Thank you, Laura. So Dr. Ross Stimpson will now speak to the benefits and facts about FIT and the indications for requesting or testing with FIT.
Thank you very much, Tunji. So yes, I'd just like to go through some of the pertinent factors that regards to FIT and the use of the test, as well as the indications for testing. Next slide, please. So as Laura mentioned, we instituted our new FIT program in June of this year. I think if you look at some of the goals and objectives of our program, you'll be able to better understand under what conditions we should be using FIT for our patients. First of all, our goal is to provide FIT to all eligible individuals in Manitoba. There's a significantly reduced incidence of cancer and cancer mortality with the use of FIT. The test is much improved in terms of advanced adenoma detection. Advanced adenomas, of course, are the precursors of cancer in most cases. Also, by providing FIT to all eligible individuals, we hope to improve screening uptake and reduce program costs. We also want to deny access to ineligible individuals or also for inappropriate indications. We try to participate, program participation with our FIT program. As Laura mentioned, we do have an automated recall for eligible individuals post-screening. So if you've had a negative test and you're still eligible, you will get another test in 2 years. Also, when patients submit their FIT tests, we do ask for patient risk information from the patient in terms of family history. And we use this information as well as the review of the colonoscopy results if they have a positive test to provide future recommendations for providers or provide a FIT recall for patients that qualify. We also want to promote adherence to established guidelines, and this supports our central endoscopy intake in the province. And this has the effect of preserving endoscopy capacity. We want to reduce the low-yield colonoscopies and wherever possible, use FIT as a replacement where it's appropriate. Next slide, please. So just to briefly summarize some of the differences between the guaiac FOBT and the FIT test here. The previous guaiac FOBT was had significant issues with interference from animal blood, drugs, and peroxidases in diet, which led to false positives. It detects all GI blood. The new FIT test here just detects human blood, as specific for human blood, and in particular, undigested human blood. This means it's much more specific for colonic rather than upper GI blood loss. So it's not a good test to screen for blood loss throughout the GI tract. The FIT test, along with the OC sensor analysis apparatus, allows for a quantitative analysis. It's much more accurate and allows us to control the abnormal cutoff, which we've determined to be 100 nanograms per ml in Manitoba. And this is in keeping with most other jurisdictions in Canada, as well as other programs throughout the world. And as mentioned, it has improved sensitivity for cancers as well as advanced adenomas. Next slide, please. So what are the considerations for colorectal cancer risk? Well, one of the primary ones is age. In addition, the patient's family history in terms of other relatives who have had advanced adenomas or family history of cancer, personal history in the patient of previous adenomas or additional risk factors, and as well whether the patient is symptomatic. We do not recommend the FIT testing for symptomatic patients. These individuals should be investigated appropriately, usually with referral to an endoscopist or a GI consultant. Next slide, please. So what are the considerations when ordering the FIT? Well, as mentioned, ColonCheck is the sole source of FIT in Manitoba. FIT is only to be used as a CRC screening and surveillance test only. It is not a diagnostic test. It is much more specific for colonic bleeding only, and it has very somewhat limited detection of gastric and upper small bowel bleeding. It is not a replacement for GI consultation or diagnostic endoscopy. In individuals that have symptoms such as bleeding or unexplained iron deficiency anemia or other abdominal symptoms such as a change in bowel habits, these individuals should be referred for consultation. The FIT is dispensed in keeping with our screening and surveillance guidelines. We try to restrict the access to those that will benefit. It doesn't replace screening colonoscopy with a high-risk family history. We can accommodate and will accommodate in the future some non-recommended higher risk colonoscopy indications based on some patient comorbidities and preferences with adjudication. Next slide, please. So when we look at average risk ordering for the FIT test, the test is restricted in the program to individuals 50 to 74 years of age, and this is our active recruitment age. Under 50 years of age, we do not recommend screening with FIT. If there are concerns about individuals in this age group, they can be referred for endoscopy or for GI consultation and assessment. In individuals 75 to 85 years of age, routine screening with FIT is not recommended. This is because individuals in this age group are less likely to benefit from FIT. We ask PCPs to review their patients, look at their life expectancy, past screening history. If they're up to date with screening, they're less likely to get benefit, or if they have significant comorbidities. If they feel that individuals in this group are healthy and would benefit, then they can order a FIT test. We do not dispense the FIT test for individuals greater than 86 years of age and greater. Next slide, please. So when you're looking at overage screening and surveillance, what are some of the considerations? Why do we restrict it? Well, there's an increased risk of complications and morbidity related to colonoscopy in this age group. There's less benefit to these individuals. They're unlikely to benefit, or the life expectancy is less than 10 years. And again, individual comorbidities in these patients may negate any benefits from screening. Next slide, please. These are some of the recommendations from prominent guideline societies here on screening over the age of 74. The Canadian Task Force on Preventative Healthcare in 2016 recommended not screening individuals aged 75 years of age and older. The U.S. Multi-Society Task Force in 2017 corroborated this and stated that individuals who are up to date with screening and have previous negative screening tests, particularly if they've been colonoscoped, PCP should consider stopping screening at age 75. And U.S. Preventative Services Task Force does say, however, that individuals in this older age group of 76 to 85 may benefit from screening, though it's difficult to say. But again, states the fact that evidence suggests that the harms are likely outweigh the benefits in this group. Next slide, please. So we look at our program in terms of overage FIT screening and surveillance. We have made age-related amendments to our current FIT screening guidelines. Again, no programmatic screening over age 74. Selective screening for 75 to 85 years of age on PCP request, and no screening greater than 85 years of age. And this includes individuals who are deemed to be at some increased risk due to family history. When we look at our surveillance guidelines, we will continue to provide FIT for low-risk adenoma surveillance, and that is really the only surveillance indications. We will decline all FIT requests in individuals greater than 85 years of age. And again, this is something which is being looked at by guideline societies in terms of gathering further evidence on when we should be stopping surveillance in all individuals. Next slide, please. So these are our increased risk guidelines at ColonCheck. These were formed with the Canadian Association of Gastroenterology guidelines, as well as combined with guidelines from the Multi-Society Task Force in the USA. Well, one first to be relative diagnosed with colorectal cancer after age 60. These individuals have limited or very slight increase in risk. The recommendation for them is colonoscopy every 5 to 10 years, starting at age 40. However, FIT every 2 years is an alternative. If they have one or more individuals relatives, one or more first-degree relatives with advanced adenomas at any age, they can also participate in FIT screening every 2 years. If, however, you have one first-degree relative diagnosed with colorectal cancer before the age of 60, or 2 or more relatives who are first-degree diagnosed with colorectal cancer at any stage, FIT is not an alternative, and these individuals should undergo colonoscopic surveillance. So this is just a summary in terms of adenoma surveillance. We recently updated these guidelines, and these are on our website here. We've had significant input into making these guidelines from clinicians in the province here as well. These are compliant with other guidelines in Canadian screening programs, as well as the US Multi-Society Task Force guidelines. You see here that the only option for which we offer FIT is those individuals with low-risk adenomas, that is, individuals with 1 to 2 tubular adenomas with no evidence of high-grade dysplasia and all adenomas less than a centimeter. Next slide, please. So this is just a summary of our ColonCheck FIT eligibility. In terms of FIT exclusions, we exclude individuals with a past previous cancer diagnosis, GI cancer diagnosis, who are in the cancer registry. If you've had a FIT or an FOBT in the last 2 years, we will not provide you a new test until that 2 years is up. For average risk individuals, we do not provide the test less than age 50 or greater than 85 years of age. In terms of colonoscopy intervals, it is our program policy to recall individuals who are eligible 10 years after colonoscopy as per guidelines. Now, this assumes a previous complete high-quality procedure with an adequate bowel preparation. And these individuals, and there's evidence in the literature suggests as well too, that there is a protective effect from a negative colonoscopy in average risk individuals, which lasts up to 10 years. And we will automatically re-invite these individuals. One change that we put into, other slide, please. One change we've put into our FIT ordering here is we now allow primary care providers to order a FIT in average risk individuals if they've had greater than 5 years since their last colonoscopy. And we did have feedback from primary care providers who wanted to order colonoscopies on their patients. And the information that we had was that sometimes PCPs do not have evidence about the quality of their previous colonoscopy. There's previous colonoscopies that were poor quality, may have been incomplete. And this allows PCPs to do a risk assessment on their patient, review the quality of the colonoscopy, and in other circumstances, also follow endoscopist recommendations who may have recommended colonoscopy in less than a 10-year interval. Next slide, please. In terms of FIT ordering exclusions in our increased risk category, this again includes those individuals with some increased risk due to family history. We also have a cutoff of 5 years for colonoscopy. This complies with our ColonCheck guidelines. Individuals who have been previously diagnosed with advanced adenomas or have undergone high-risk family screening would be getting colonoscopy within this 5-year interval. And this allows us to have a transition from colonoscopic surveillance to FIT after 5 years in those individuals which would qualify. In terms of rejections, if we do reject you, we will provide a reply letter for any refusals with an explanation, and you do have the option of dispute and adjudication in terms of putting your case forward as to why your patient should get a test. Next slide, please. This is our ColonCheck ordering form here. We have modified it slightly. Next slide, please. So we now only have a cutoff for colonoscopy within 5 years. Again, we've put our indications here in terms of average risk screening, and then PCP request for individuals age 75 to 85. For others here, we do have some other indications here, such as young individuals who received radiation treatment or transplant candidates that we have allowed the test to be used for, as there is certainly a demand for this. Next slide, please. So just in some summary here, in terms of the test indications, we do not accept non-screening indications. The test is not intended to be used for the investigation and management of abdominal symptoms, investigation of iron deficiency anemia. These individuals that undergo endoscopy. It is not to be used for the testing of blood or a history of rectal bleeding. If you have a positive FIT or a guaiac FOBT test, that's enough of an indication for colonoscopy. You should not repeat the test. A negative test after a previous positive test does not mean that you do not need colonoscopy for follow-up. And this is the nature often of GI bleeding, which can be intermittent. If an individual's had an incomplete colonoscopy or a poor bowel prep, the scope should be repeated. If it can't be repeated, use an alternate method of visualization, such as CT colonography. And of course, under overage in the guidelines. We may accommodate, in some circumstances, atypical screening or surveillance requests. Individuals who are not medically fit or can't tolerate a colonoscopy or a bowel prep, we will provide the test in these special circumstances if you do request it. They would, of course, need an alternate method of visualization of the colon if you got a positive. Next slide, please. So just quickly in summary then, their FIT is indicated for average risk individuals. One first-degree relative diagnosed with a CRC greater than age 60, first-degree relatives with documented advanced adenomas, and then in surveillance cases, those individuals that have had low-risk adenomas may be also eligible for a FIT. Thank you very much.
Thank you, Dr. Stimpson. We will now have Dr. Alicon speak to us about when it is appropriate to use FIT in clinical practice for colorectal cancer screening and surveillance.
Thanks, Tunji. So I think it's important to kind of get a practical sort of understanding of where these sort of guidelines are going to occur in the clinical setting. So we thought it best to give you some scenarios to look at and then have a poll for you guys to put in your votes to see what is the appropriate test at that time. So we'll start with the first question there. So which of these patients are appropriate to refer for FIT? The first one, 35-year-old male with ulcerative colitis, 56-year-old female with newly diagnosed iron deficiency anemia, 72-year-old male with coronary artery disease, atrial fib on dual antiplatelet therapy, 62-year-old individual with weight loss and a change of bowel habits. I'll give you about 20 to 30 seconds. Okay, so patients who've got a history of inflammatory bowel disease, as everyone sort of indicated there quite well, should be followed by a specialist there who will make the appropriate sort of interval endoscopy surveillance timelines of assessment there. Patients with iron deficiency anemia, alarming symptoms, so new persistent abdominal pain, change of bowel habits, diarrhea, constipation, unexplained weight loss, exhaustion. They're having issues with tenesmus, incomplete evacuation of their stools. These are patients who are unnecessary to send in for stool testing, and that can actually lead a delay in their diagnosis. As for patients who are on anticoagulants and anti-inflammatories, this is not a contraindication to screening for asymptomatic age-appropriate individuals. We'll go to the next question there. So true or false, people with menorrhagia cannot undergo FIT testing? Yeah, so very good. So people who've had any sort of recent dental work, they've recovered from some benign bleeding issues such as hematuria, they've had some menstruation concerns. Because the FIT test detects colonic bleeding, it is something that they can safely proceed with. It is advisable for them to at least wait 3 days for the bleeding to have resolved before they go ahead with the FIT test. Or the third question there. So which of these patients are appropriate for to request a FIT test? An asymptomatic 52-year-old with a genetic testing that's been positive for Lynch syndrome, 86-year-old asymptomatic healthy individual with a first-degree relative at 60 years of age with colorectal cancer, 55-year-old asymptomatic with sickle cell and second-degree relatives with polyps, 42-year-old with ongoing bleeding despite treatment for an anal fissure. So patients who've got hereditary colorectal syndromes are at actually high risk, and they actually should be referred to a specialist to review for colonoscopy, and they shouldn't be sent in for FIT testing. Considerations for deciding when to screen patients aged 75 to 85 include, as Dr. Stimpson had alluded to, their previous screening history, what are their comorbidities, potential benefits and harm of screening with a colonoscopy there. Also taking into effect how long and whether they be willing to follow up with a colonoscopy. As for any patient with overt bleeding, this should actually be referred to a specialist for further review, as these patients are not going to be benefited with a stool test that will reinforce the fact that they already have bleeding. As for the question with regards to the hemoglobin variants there, patients with sickle cell, thalassemia, based on the present evidence, these patients are safe to be screened with no interference, as the FIT test detects blood in the stool using polyclonal antibodies that recognize different sites on the molecule there. We'll just go to the last question there. True or false, is it appropriate to order FIT in urgent care to help differentiate between upper or lower GI bleeds? So FIT does not detect upper GI bleeds due to the breakdown of the hemoglobin in the intestinal tract. Positive FIT test will actually make no difference on how often a bleeding source is identified and on the result of going to endoscopy, and actually may delay the decision of the care. So it's important in these patients who have evidence of overt bleeding that we're not looking for occult findings for FIT testing that can delay their ongoing progress of care. Okay, very good. So I'll hand this back to Chunji.
So next slide there. So thank you very much to our speakers. We'll now be moving to the question and answer portion. Questions submitted during the registration will be addressed first, and then we'll take a look at the additional questions that have been added to the Q&A box. So we'll go to the first question. So question number one is, going forward, should I be filling out and faxing all FIT forms for patients who require FIT test regardless of age?
I'll take that one, Dr. Fatoy.
Thank you, Laura.
Yeah, it's a good question, and I appreciate drilling down on this a little bit more. I know Dr. Stimpson did touch upon this, as did Dr. Khan in their presentations, but the short answer is no. We ask actually that you refer to the Manitoba Cancer Screening Guidelines to determine if your patient is eligible for FIT. Generally, average risk persons should be between the ages of 50 to 74. And as Dr. Stimpson said, some people at increased risk could begin FIT screening at 40. But upon a health care provider's request, ColonCheck is going to send a kit to people between the ages of 75 and 86, but the onus is on the healthcare provider to ensure that the benefits outweigh the harms in people in this age category. So if you have any doubt on the eligibility of your patient, you can either refer to the guidelines as I suggested. You could access the CancerCare Manitoba website that's shown at the bottom right corner of this slide, or you could also call ColonCheck directly and we can try to answer any questions that you might have.
Thank you. So question number 2 says, why has the administrative burden in ordering FIT been added?
I'll take that one too, based
You
on
will. Thank you, Laura.
it's a more of an operational question. Happy to answer. So, regarding the administrative burden, I'm assuming that this means the practice of requesting a FIT using the FIT requisition form that's available on EMRs and on the website. The process of completing and submitting a requisition should be really very similar to the process done previously within your practice, in that you would have generated a requisition and either provided it to your tied lab or given it to a patient for them to take to the lab to have given to them. So realistically, this process should be very similar. And now we're just asking that the providers send the requisition direct to ColonCheck and not give it to the patient. And in many ways, we're hoping that this process is actually better, because you can be assured that ColonCheck will send your patient a FIT kit. In the previous method, we're depending on the patient to go to the lab and pick it up. So not sure that that always takes place.
Thank you, Laura. So next question. What are reasons FIT requests are rejected? I think Dr. Stimpson will take this.
Okay, thank you. Thank you, Tunji. So, I mean, some of the commonest reasons that FIT requests are rejected is that patients have had a FIT or an FOBT within the last 2 years. We have seen circumstances where even after colonoscopies, FITs have been ordered in very short intervals, such as 1-2 years. We do only provide the test every 2 years. A lot of the also rejections we had in the past were individuals who had had a colonoscopy within the last 10 years who are average risk. As mentioned, we've now changed that. We've tried to respond to concerns from primary care providers. All requests for the test will be rejected if they've had a colonoscopy within 5 years, but PCPs now will have the option of requesting a test if they've had a colonoscopy greater than 5 years ago. But those are the commonest causes for rejections. We will still continue to appreciate any further input that PCPs may have and how we can improve things.
Good. The next question says, why does ColonCheck exclude patients under age 50 and over age 75? I think Ali was going to take that one.
Sure, I can talk there. So as we've kind of spoken about already, that patients who have already been through the screening program up until the age of 75, there's an evidence that there's a protective effect from their assessments in the past there. There's actually good data that these patients that are over age 75 may not get the same benefit of the screening program, and definitely after age 85. There is the option that if primary caregivers are concerned because of some specificity to that patient there is the option to ask for that for patients between 75 and 85 years of age. As for the underage group there, right now the National Institutes of Health in the United States is still looking into this data. There is some models that are saying this should be done at an earlier age. But so far, per the Canadian Association of Gastroenterology guidelines, that hasn't sort of had an effect where we've seen that benefit. This is once again for patients who are asymptomatic. If there are other issues there in regards to these younger patients because of family history of course, then that would come into play then.
Thank you. So I think someone addressed this, but I'll read it out anyways. Why are patients excluded after a normal colonoscopy?
Sure. So I'll speak to that again there. Essentially, we aren't excluding these patients. We're actually just increasing the interval. So these patients have a protective effect from the colonoscopy that we know from good data. Again, this comes from the National Institutes of Health there. They've shown that the chance and indications for patients after a proper, well-prepped, bowel prep colonoscopy of finding in 1 to 5 years period of time a polyp of any concern is about 3.1%. If you look at that sort of interval extended to about 5 to 10 years, the difference was 3.7%. So there's not really a significant interval change after someone's had an appropriate colonoscopy assessment done. As per what Dr. Stimpson had talked about during the presentation, there is the caveat that at the present time, as we're transitioning over, that if there's not information about previous colonoscopies or the benefit of how well they were prepped, then that 5-year sort of interval is allowed for.
Thank you. So question 6 here says, is FIT available for non-screening purposes? For example, the elderly or people that are unable to tolerate or have a scope.
Sure, I'll take that one again, Tunji.
Okay.
So I think that when we're looking at these sort of requests this is probably where it's probably best to have a consultation with an endoscopist to allude a little bit more information. So is there other significant medical issues with these elderly patients? Is it a problem where they can't do the bowel prep? Is it an issue of they're not having an understanding of what's all involved there? And if the primary caregivers can't answer all those questions, then it may be an option to have that consultation. In some of these patients, there is the option of a CT colonography, but again, that requires a bowel prep. In my experience, talking to some of these patients there, especially the elderly patients, a lot of them will say that even if you found something, I'm not willing to go to the next step of endoscopy or if further intervention is needed. So then it's probably not fair to put them through a test where we're not going to be able to follow up with them on the next steps there. And that just needs a bit of discussion. So that's sometimes not just easy to put down on a form.
Thank you. Question 7 says, post-scope recommendation is not to rescope for 10 years, but is it not putting patients at risk, not doing a FIT test in between? And I think we addressed this, but Russ, can you speak to it a little bit more?
Sure, thank you very much. I think Dr. Khan just spoke to this quite well. With a good quality colonoscopy, as I mentioned, there is a protective effect, which we believe that lasts 10 years. This is a very common recommendation, not just in our program, but in other programs. We will not reinvite individuals in less than 10 years. We do assume that it's a good quality colonoscopy. If something changes in the family history, for example, or there's concerns about the previous scope quality, the PCPs now have the option of ordering a FIT test after 5 years from the previous colonoscopy. So, yeah, so this is basically a program recommendation, but for individual circumstances related to that patient, where there's additional factors and concern about the scope, yes, a FIT test can be ordered after 5 years. But I think the important thing to remember is that if your patient has had a scope which is of poor quality, is incomplete, it's important to either repeat the scope or do another confirmatory test that it's actually clear, such as CT colonography, and don't order a FIT test. A FIT is not a replacement for a colonoscopy.
Thank you, Russ. So next question here says, can site-specific lists be generated? Not quite sure what this means, but maybe Laura can help us with that.
I think I might know what it means. I'm assuming by the term lists, we're talking about a screening status list that perhaps a smaller community might be requesting on this screening status of the patients they serve. Unfortunately, for FIA reasons, we can't create and share lists for communities to work off to recruit specific patients to participate. But we are happy to partner with communities to help increase the screening rates in their patients and in their community. So upon request, we can provide individualized screening status reports. It's not a report as extensive as, for those of you who may be familiar with the cervix check screening history, it's not as comprehensive that, but at least it will let you know of their up-to-date status, whether they're due or overdue or never completed. We can work together to create a colon cancer screening campaign, or we can force a mail out to target populations such as defining age or screening status, overdue versus never participated, or even by postal code. So there's opportunities to access those people that are eligible and underserved, but we just can't provide you with a list to tell you who it is in your community.
Thank you, Laura. So question 9, I think this is the last one that came before. Can I make a referral for my patient who had an abnormal FIT test result? I'm assuming this is a referral for scopes or something. Who wants to take this one?
I can take it. And again, we're asking that no, you don't. We are going to initiate, because we're getting the electronic result being sent to us from CADM Lab, we are acting on it on the day that we receive that test result. We're reaching out to communicate with the patient right away to advise of that test. And we're arranging for that NP pre-procedure appointment. So in order for us to work efficiently and get those patients referred as quickly as possible, we don't want healthcare providers also doing it at the same time, causing some confusion. So we will be sure to keep the healthcare provider advised of every step of the way, and you can have the confidence that ColonCheck is initiating this referral for you.
All right, so we will go to other questions that came in the Q&A. I see a number here, so yeah, I'll go by the time they came in. So first one is, I have had FIT test requests for patients rejected due to remote history of colonoscopy, despite the recommendation to return to FIT/FOBT testing. What am I supposed to do in this situation? Kira would like to answer this question. No, who would?
I can answer.
Yeah,
Okay.
thanks, Ross.
I can answer that, Tunji. So,
all right, thanks, Ross.
I guess, I mean, I guess a little more detail might be needed here. I guess the first question is, what exactly was the recommendation? What were the findings on the colonoscopy? I mean, we do get inappropriate recommendations from endoscopists as well too for future screening and surveillance. If it was a good quality colonoscopy, and there's no other risk factors than 10 years to return to FIT, or even 10 years to return to colonoscopy, if you're doing average risk colonoscopy, would be appropriate, that we try to discourage that. I think in a situation like this, I would try to clarify with the endoscopist as to what an appropriate recommendation would be in this circumstance. As mentioned, there is an option to return to FIT after 5 years after colonoscopy based on primary care provider's assessment of the patient. But I think in a situation like this, you really do need to clarify. We've seen a lot of, I would describe them as some inappropriate recommendations for future screening from endoscopists. Sometimes they recommend a FIT early because they weren't happy with the examination they did, or the prep wasn't quite good. And again, that goes back to an issue of whether you should be repeating the procedure or looking at a different method to visualize the colon, such as CT colonography. So I think it really needs some clarification from the endoscopist.
Okay. So next one, I think this is one that we've talked about a little bit. Maybe I'll read the next two. So it says, what about if a patient did a colonoscopy in the past and the surgeon recommended FOBT in 5 years? So it's similar to that. And then the next question is, I have a patient with Crohn's and colitis. Can I order FIT testing for colorectal cancer screening?
Sure, I can take that, Tunji.
Thanks,
So
Ali.
we did that sort of, as for the latter one, the inflammatory bowel disease, these patients are already in the care of endoscopists, gastroenterologists there. They have frequent scopes done on a regular basis sometimes. So there isn't any benefit of having them in the FIT algorithm of being screened for asymptomatic, because most of these patients are symptomatic. As for the issue of recommendations from previous endoscopists there, especially because we need to look at the specifics there in terms of was there a reason that the previous surgeon endoscopist had recommended it. The program has determined that a 5-year sort of interval is going to be acceptable as we transition into the future there. So on that question alone there wouldn't be an issue. The patient could be considered for FIT testing after that 5-year interval. But going forward, once we have the program instituted there, and with the confidence of knowing what the results from the endoscopy are, then likely we'll be transitioning further in the future to the 10-year timeline.
Okay. Thank you. We have a couple here that I think are quite interesting. So is there any role in using FIT for individuals who are less than 50 years old who have a first presentation of diverticulitis and have no other higher risk colorectal cancer risk factors versus referring them directly for colonoscopy?
I'll take that one again there, Tunji. So we see quite often patients who present to the acute care surgical services with diverticulitis. They have concerns for either occult or obvious rectal bleeding in these patients there. And there is a concern of misdiagnosis of missed polyps and stuff. So actually there isn't, once again, a benefit of putting these patients to FIT. And most of these patients should be followed up with an endoscopy within a period of 4 to 6 months after their diverticulitis anyways. So they should be followed up at least by their surgeon or a gastroenterologist, and then make that determination for an early surveillance in terms of endoscopy.
Good. So next question says, since FIT cannot detect blood from the upper GI tract, can we have the FOBT back for that indication, as FOBT has been removed from our ordering ability since FIT rollout?
I can answer that, Tunji,
Thanks,
if you'd
Ross.
like. Okay, so as we have mentioned, I wouldn't say if it won't necessarily detect any bleeding from the upper GI tract. It's not exclusively specific for colonic bleeding, but it is less effective at doing that. And you're right, the FOBT, the guaiac FOBT in the past would detect bleeding at any site in the GI tract. However, if you are concerned about blood loss in the upper GI tract, again, as Dr. Khan has reiterated, I think that individual needs to go for endoscopy. That would be the appropriate course of action to take. I do understand, and we are getting a lot of feedback from primary care providers who have used guaiac FOBT in the past, and that was because it was available from all sources, DynaCare, Shared Health, as well as the screening program, and they use it to help guide them in their management of individual patients. An example might be a patient who had previous GI bleeding and iron deficiency anemia and may have a low hemoglobin again, and the patient had been properly investigated. They might want to use a guaiac test to confirm that there was some ongoing bleeding. We are looking into specific issues related to the use of we'll call blood tests for diagnostic testing. The FIT would not be appropriate for that circumstance, but for the most part, if you follow the algorithms for looking at anemia or for GI bleeding, FIT is not an appropriate indication is not appropriate in that circumstance, and neither is a guaiac FOBT test. But we will be looking further into this. And remember that even if you get a negative test in that circumstance, it doesn't necessarily rule out bleeding.
All right. So next question, and I think it was in 2 parts. So will there be a history kept and available for printing and to be kept in the patient's chart upon request, similar to cervix check? I think that was addressed. And also, will the history also include the scoping history?
I can take that one, Dr. Fatoy. It's a great question and a great suggestion that comes with challenges. Although I mentioned previously that ColonCheck possesses the colorectal cancer screening database registry, it shows episodes of care, but it doesn't show test results if the testing was done outside of our program. So if a healthcare provider had requested a test kit for their patient and it was supplied from DynaCare, we have the date that the test occurred, but we don't know what the test result was. So we certainly can look to a future of generating some sort of episode of care. It just won't be fully complete. The one that we can verify is any testing that comes from the ColonCheck program. Also, we would also have episodes of colonoscopy that would take place, but it would really just be the date of the procedure. It wouldn't have any indication of where, when, or the findings of that scope at that time, unless, again, it was initiated by CancerCare Manitoba, then we're aware of all those test results.
All right, thanks, Laura. So next question, I think, I asked my primary care provider if I qualified for the FIT test in September. I'm a healthy 57-year-old female with no risk factors. He said no. I inquired further from ColonCheck and I received an email saying I didn't qualify. So I went ahead and did the FOBT. Then a couple of weeks ago, I received a FIT mail out from ColonCheck. And, I'm confused.
I'll tell you that. I would say I'm a bit confused too about that. I think that what I could report is that ColonCheck will distribute a FIT kit to anybody who is eligible upon us receiving a request for it. So there's lots of complications in this issue. I can't really speak unless it was something to do with the FOBT had been completed within the last 2 years and it wasn't that they weren't eligible. It meant they weren't eligible or due right now. And when they became due, it triggered a recall for us to send a test kit. That might be what happened in this situation.
Thank you. So next question says, if ColonCheck is doing the referral for colonoscopy, if the patient is rural, would that still take place in Winnipeg, or would it be closer to home if general surgery in a rural area also does colonoscopies?
Yeah, thank you. I'll take that. We would make the referral. I mean, it's a conversation with the patient. Sorry, my light in my office just went off. We would have a conversation with the patient to find out what SDO they are part of and which facility that provides endoscopy is closest to their home. And we would make a referral appropriately. So if it's somebody in Swan River, we would make the referral to Swan River, or Minnedosa to Brandon, those kind of things. Theoretically, the only ones we would be referring to the WRHA would be folks living in the WRHA or those who seek care regularly in the WRHA.
So we have a couple questions. I think we have only about 1.5 minutes. It says, if a patient who reports a black bowel movement, what would be the next test? FOBT can no longer be ordered. Is that correct? And who wants, I think we addressed that. Who wants to,
I can address it if you like.
Thank you.
Kenji or Ali can pipe in here. So when an individual that's had a history suggestive of bleeding, they need to be referred for endoscopy. Again, if the bleeding is intermittent, an FOBT or a FIT, even if the bleeding is from the colon, may not detect that. So they need to be properly investigated, and this fits under the heading of a symptomatic patient or an individual with signs or symptoms of disease that needs to be investigated. So any kind of occult blood test in this circumstance would not be appropriate.
And lastly, says, did you indicate that PCPs send you the request for the test, but also required to be sent the requisition for the test from CADAM lab?
No, the request comes to ColonCheck CancerCare Manitoba. The test kit will come with a return form that the patient needs to fill out, and that form goes with the completed test to CADAM lab.
Okay, so it seems like we've run out of time. I thank you everyone for attending today, and thank you for all your questions. Look for the posting on the CancerCare website in a few weeks or so. And once more, thank you to our panelists for being here.
Thank you very much, everybody.
Thank you.
Thank you so much.